there, but we train mikveh attendants, we train Kala teachers, we have community evening. Karen does a podcast for us on a regular basis. Also, Sharon Galper Grossman does a podcast related to medical issues on halacha. And we try to address issues of women's health, well-being, and intimacy in lots of different ways. So this is just one aspect of our work, and you can see more things in the back. This booklet was actually a long time coming, almost as long as the symptoms of menopause last. About 5 years ago, we had an evening about breast cancer in a frat, and somebody who was there approached me and she said, you know, we're all women. And it's nice that you're talking about, different things that might happen that affect the mental experience, but one day we're all gonna stop going. Why doesn't anybody talk about that? And why doesn't anybody talk about the changes that happen in your body around that? There's nothing out there. So it took a while to percolate, but we decided that we would put something together. So what this booklet does is it outlines first some of the more the medical, the emotional, the spiritual. Jacqueline Rose has a piece in here about change, nutritional things, medical tests that you should continue to do. The second section gives voice to the conversation that seems so absent, which is about the spiritual side of what menopause is, and we're going to talk about that for a minute. Then there's a section which gives some suggestions for marking the transition around mikvah and not going to mikvah anymore. And then finally, people share their personal experiences about menopause, either about menopause or leaving mikvah. And I think that within it, there's something for everybody to relate to. And if you don't relate to it, please write to us, because we definitely want to give voice to the conversation and put out more things and let more people share their experience within. When we thought about how we could celebrate it, and I'll let you all read it at home, we decided that we really wanted to open the conversation, to give some tools and resources, and to help educate you about the different aspects of what the stage is. Because most of us are going to live 30 to 50 years, and that's stream to everybody, past when we no longer have our periods and from when we go into menopause. So before I pass on the baton to the speakers on the topics, I just want to think for a minute about the spiritual side of menopause, and I'll try not to overlap with what Karen's going to say, but I just want you to think, how will you note this transition from a spiritual point of view? Every system of our body goes through change. We're going to hear it, whether it's emotional, cognitive, physical, nutritional needs, all of those, and we'll cover a lot tonight. But also from a spiritual point of view, we have to recognize that this is a time of incredible potential. And the question really is, can you take your life experiences and what it is that you need going into the next stage of life and invite Hashem in to be partner with you as you do that. And what creative energies do you have that you want to take forward? What are the deeper life lessons? What are the wisdom that you have learned that you can take? Karen and I spoke about the fact that we're not going to mention this, but I'll mention for 1 second that it's Gemara, and the sources, it calls the time going into menopause stena. You're a stena, and I was like, absolutely not putting that in our booklet. But then somebody told me that it stands for Zezo Kanta Chochma. And I really feel like each one of us has gained life wisdom. Even though I'm not willing to use that term, I am willing to accept what it has to say about us in our own being, our knowing things in a different way. And I hope that each and every one of us will tap into, okay, what are my strengths? And what do I want to focus on as I move through to the next stage? So I also invite you to think about, if you are still at the stage of saying goodbye to the mikvah, how you want to do that. we'll talk about that afterward in my breakout room, and delve more deeply into the booklet for all the different pieces. So with that introduction, I invite Karen back up to move to the next section. Thank you. Thank you all for coming.
Okay, so we're going to have our keynote speaker now, which is the main event of the first half of the evening. I'm going to speak for a short time after that. And then we're going to move into breakout rooms, 3 different choices. We'll give you more information as the evening goes on. I'm for now just going to introduce Dr. Joanne Abrams, who made Aliyah 3 years ago from Johannesburg, South Africa, where she had her own practice focusing on women's health. She works as a family doctor in Netanya. She lives in Telmond with her husband, and they love when they're kids. So that's it for Shabbat. She has a particular interest in helping support women as they go through the transition and run up to menopause in this stage of life. So thank you, Dr.
Wow, didn't expect such a huge turnout. Okay, but anyhow, good evening and welcome everybody. So the title of this talk is Menopause, What Your Mother Never Told You. So the first thing I did was to call my mom in South Africa and ask her about her menopause experience. And she laughed, she didn't say much, but she said she does remember my younger brother commenting at the time that she was acting very strange. That's all she could tell me. Okay, so in Bereshit, in Vayera, we read that a pasuk that says, Chadal liot lesara orach kanashim. It has ceased to be with Sarah, the way of the woman, and she laughed to herself at the thought of having a child at her age. Not only does this ancient text reveal the existence of a postmenopausal woman, but it also reveals a postmenopausal woman with an intimate understanding of what she should expect at her stage of life. I do feel quite strongly that as a family doctor, we are often the first point of contact when a woman presents with any of the symptoms that are now considered part of the whole complex menopausal basket. And if we look at some of the stats, which are quite interesting, 1 in 3 women aged 45 to 55 received an incorrect diagnosis or treatment related to menopause. 32% felt that their doctor was not knowledgeable enough, and 60% felt that the advice they were given was not helpful. A while ago in Netanya, a 53-year-old woman consulted me for an unrelated problem. But in the consultation, she told me that she was so confused about whether to take hormone replacement or not, and how to manage her menopause. My reply, in all honesty, was that I also was, and I was still looking into the research. She joked with me that once I figured out what to do, I should let her know. So as a result, I was compelled to actually first acknowledge that things were starting to change in my own body, and that I needed to address these issues. Also, that the training I received in medical school regarding menopause was outdated, inappropriate, and possibly wrong. So first, I want to just discuss the biology involved, and then we'll see that it isn't just about the ovaries stopping to make estrogen, but it's rather a complex, holistic process that can affect most of our anatomy and physiology. So Dr. Jen Gunther in this book, which is called The Menopause Manifesto, she beautifully writes that to begin with, you have to go back to your grandmother's pregnancy with your mother to see the interconnection of intergenerational women. When your granny, Safta Boba, also carried in her pregnancy of your mother, the primordial follicle that was inside one of your mother's ovaries that was destined to become you. So we're all connected, going back generations. We are born with all the eggs we will ever have, but over time, these eggs lose their quality and become fewer. Less hormones are produced by these follicles to trigger the normal menstrual hormonal cascade and sustain a normal menstrual cycle. We get menstrual cycle disruption, and ovarian functions continue to decrease, and eventually menstruation will stop. As the ovaries stop sending out all these hormones, estrogen, progesterone, testosterone, the hypothalamus in the brain sends out something called gonadotropin releasing hormone. This stimulates the pituitary gland, also found under the brain, to produce more push hormones, FSH and LH, to try to push out more follicles in the ovaries. So that's why we do see in menopause the FSH and LH rising, although we don't recommend testing these levels because it's so erratic and can vary from day to day. Ovaries are not the only place in our body sensitive to these hormones. So as a result, the symptoms that this drop in hormones can create are vast. And I struggled with this because I don't want this to be a list of oives, but at the same time, it is a list of oives. However, I think knowledge gives us the opportunity to ask questions and find the help that we need. I'm going to read out a list which is written in this book by a woman who's all over Instagram at the moment. I don't know if you found her. Her name's Dr. Mary Claire Haver, and she's written The New Menopause. So she writes it quite nicely. I find it a little bit medicalized, but she does summarize everything very well. So what she does is she lists a list of symptoms that most likely are connected to your menopause. And I'm just going to go through them. Acid reflux, acne, alcohol intolerance, anxiety, arthralgia and arthritis, asthma, autoimmune diseases, bloating, body composition changes, body odor, brain fog, breast tenderness, brittle nails, burning sensation in mouth, chronic fatigue syndrome, crawling skin sensation, decreased libido, dental problems, depression, difficulty concentrating. We're still only on D's, sorry. Dizzy spells, dry or itchy eyes, dry mouth, dry skin, eczema, electric shock sensations, fatigue, fibromyalgia, frozen shoulder, genitourinary syndrome, headaches, heart palpitations, high cholesterol, hot flashes, incontinence, insulin resistance, irritable bowel syndrome, general irritability, itchy ears, itchy skin, kidney stones, memory issues, menstrual cycle changes, mental health disorders, migraines, mood changes, muscle aches, night sweats, fatty liver disease, osteoporosis, pain with intercourse, sarcopenia, which means loss of muscle mass, sleep apnea, sleep disturbances, thinning hair, thinning skin, tingling extremities, tinnitus, TMJ issues, unwanted hair growth, those chin hairs, we know about them, vaginal dryness, vertigo, weight gain, and wrinkles. So she really covered everything. All right. So 85% of perimenopausal women experience a wide range of these symptoms that can have an impact on the quality of life. Only 60% actually seek help, and yet 75% go untreated. So the medical definition of menopause is actually only one day. It marks the day of your last menstrual period 1 year previously. The time before that is called perimenopause, and the time after is postmenopause. But the symptoms don't comply with that definition. The only predictable thing about menopause transition is its unpredictability. So personally, I prefer the Hebrew name for menopause, which is Gil HaMa'avar. It's a time of transition. And in South Africa, the local women would refer to as the change of life. And I just think that's much more succinct than menopause, which just to me is just a pause or sensation of something. So menopause can be considered like puberty in reverse. And when I think of the difficulties of those puberty years, I would much rather be going through this transition with the wisdom and self-assurance of a 50-year-old woman plus, and not a fragile, insecure tween. So generally in medicine, if someone's thyroid stops working, we give them thyroid hormone. If a pancreas stops working, we give them insulin. If a pituitary gland doesn't work and a child doesn't grow, we add hormone replacement, growth hormone. But menopause is the only condition in the body where there's a known lack of specific hormones, yet the treatment options have been so inconsistent and have gone through so many dramatic swings that there's no trusted foundation, and there's just no trust that's been established between women and the pharmaceutical companies. In 1998, the Women's Health Initiative launched menopausal hormone therapy trials to create a gold standard for the use of hormone therapy and its effect on cardiovascular disease and cancer in postmenopausal women. The trials were stopped in 2002 when they announced that it caused there was an increased risk of breast cancer. The media took off with this and created a fear of any hormone replacement therapy. But if you analyze this more deeply, they found that a woman has a 4 in 1,000 per year risk of developing breast cancer without hormone replacement, but with added estrogen and progesterone, she has a 5 in 1,000 women per year chance. Unfortunately, the media reported on the relative risk, which is 25%, and not on the absolute risk, which is much more representative of the true risk, and this is 0.08%. So practically overnight in America, 80% of prescriptions of hormone replacement were stopped and few new patients were offered treatment. In 2022, the Menopause Society issued a statement that absolute risks are far more useful to convey risk and benefits in the clinical setting, and that healthcare professionals need to understand basic concepts of relative and absolute risk to communicate the potential benefits and risks of hormone therapies. Every day at work, I feel I see the fallout of this incorrect information and media frenzy. Our clinic in Netanya, we see a lot of 70-year-old women, and these are women who 20 years ago may have been candidates for hormone therapy. And now they're coming into me with urine incontinence, osteoporotic fractures, diabetes, memory, and cardiovascular issues. However, it's important to note that research has not shown that every symptom that I listed before has been proven to be cured by adding estrogen. And we still need a lot more research on the best treatment of many of those symptoms. We do know that estrogen is considered a protective hormone. So when it diminishes, stress hormones like cortisol and other pro-inflammatory factors become more active, creating an inflammatory event which can affect many organ systems. So as a result of menopause, you are at increased risk for osteoporosis, coronary artery disease, insulin resistance and prediabetes, neuroinflammation, visceral fat gain, and sarcopenia, which is the loss of muscle mass. So some parts of menopause, like hot flushes, are a nuisance and can be incapacitating and definitely need to be addressed by your doctor. But it's also important to look at the long-term impact on our bodies from hormone withdrawal and assess everyone individually on the best treatment for them. So I'm going to look at just a few of these conditions that I pointed out. So what is osteoporosis? This is progressive bone disease characterized by brittle, weak bones that are prone to fracture. Our bones are constantly being broken down and rebuilt, but this renewal does slow down as we age and can lead to osteoporosis, especially if you have these risk factors: weight below 56 kilos, early menopause, history of heavy smoking or drinking, daily corticosteroid use, thyroid medication, warfarin, immunosuppressive medication, previous bariatric surgery, and some chronic kidney and liver diseases. So a bone density scan will show whether you're osteoporotic or osteopenic, which is the step just below osteoporosis. Hormone replacement has been shown to reduce risk of osteoporosis-related fracture, but there also are specific osteoporosis medications that are used as well. Sarcopenia. Sarcopenia is a progressive age-related condition characterized by loss of skeletal muscle mass, strength, and function. It often contributes to reduced physical performance and an increased risk of falls and fractures affecting overall quality of life. Estrogen and testosterone help muscle tissue regenerate and rebuild. After age 30, we start to lose 3 to 5% of our muscle mass each decade, and this increases up to 10% after menopause. Estrogen therapy has been shown to increase receptors in the muscle and help improve muscle power, but its impact on muscle mass is uncertain. Increasing your muscle mass plays an important role in your glucose metabolism and helps to prevent insulin resistance and type 2 diabetes. So estrogen isn't the only answer for that. They found that it's really crucial to have a good protein intake. They're looking at 1.2 grams per kilogram of protein per day. that a woman should be eating in order to help build up your muscle and your bone. And also weight-bearing exercises like weightlifting and resistance training also plays a very important role, as well as adding calcium if you are able, and vitamin D supplements. Coronary artery disease. The waves continue. Okay, this is when plaque made of cholesterol and fats builds up in the arteries, reducing the flow of oxygen to the heart muscle. Menopause is known to drive up your LDL cholesterol and your triglycerides. So we all need to be doing regular screening on our cholesterol and checking our blood pressure. Hormone replacement has definitely been shown to reduce cardiovascular disease, but it needs to be used by women started by women under the age of 60 who are no more than 10 years removed from menopause. If it started after 10 years, if it started more than 10 years after menopause, there may be actually an increased risk of cardiovascular disease, and that even increases more if it's more than 20 years. Insulin resistance. Insulin is made in the pancreas. It helps deliver fuel from your food to your cells. And if your cells become less sensitive to insulin, you develop insulin resistance. This causes high blood sugar that can be quite inflammatory to the rest of your cells. Insulin resistance can lead to pre-diabetes and eventually type 2 diabetes. Of the three, insulin resistance is the easiest one to try and reverse. And loss of estrogen can make us susceptible to insulin resistance. Research in this is not conclusive. So hormone replacement may have a protective effect against insulin resistance in postmenopausal women. They found that women on hormone replacement had a 20% lower incidence of type 2 diabetes compared to women not taking, but more research is needed before we use hormone replacement to specifically reduce insulin resistance. All right, neuroinflammation. Menopause is considered a neuroinflammatory condition. Hot flashes, night sweats, depression, memory loss, brain fog, and anxiety are all symptoms of the neuroendocrine effect of menopause. The brain and ovaries are always in communication, so the drop in estrogen causes neurological symptoms. The hypothalamus regulates our body temperature. With menopause, it becomes a wonky thermostat that tells us we are hot even when we're not. So they found that it's not the drop in estrogen that causes the hypothalamus to act like this, because young girls don't get hot flashes and they're not exposed to estrogen. A hot flash depends on a brain that was exposed to estrogen and now that's been taken away. So the faster the drop, the more profound the effect, which is why those that have had surgery to remove their ovaries often have far worse hot flashes. So this whole thermoregulatory system becomes extremely sensitive to increases in temperature and responds in an exaggerated manner. In response, the blood vessels dilate, blood is shunted to the skin to lose heat, and this can last for about 2 to 4 minutes and stops when the body feels cooler. Because you were never really hot before, the body temperature has now dropped, and then you can get the chills. So this is an overwhelming process that is happening on top of everything else in your life, your work, your family, your elderly parents, and it can be exhausting. In some women, this can happen 20 to 30 times a day at 2 to 4 minutes at a time. It's time consuming. So no surprise that it's associated with depression, anxiety, and sleep problems. These hot flashes can start during the menopause transition, even many years before the final menstrual period, and last on average 7 years. And even today, I had a woman come, she was 44 years old, and she was complaining that she had these like spells where she thinks she was been running a temperature, but then she checks and it's normal. And when I mentioned to her that it may be due to hormonal changes, she was convinced this was a post-COVID thing. And when I asked her, well, what age was your mother at menopause? And she said 45. And then she started to think, well, that's me, you know. So it was not something that she even considered. She was convinced she had some kind of infection. 25% of women have minimal hot flashes. 25% are those super achievers and are called super flashes, and 50% are in between. Smokers will have a longer duration. Alcohol, caffeine, and anxiety can also exacerbate. Hormone replacement is the gold standard of treatment, but there are other options like antidepressants that work on the same neurotransmitters and anti-epileptic drugs and clonidine, which is an old blood pressure medication. I just want to add a word on botanical preparations. It's not what I'm trained in, so I can't promote it. If you're using them, if you're comfortable with them and you feel like they're helping you, go ahead. For me, the problem is they're not well studied and often their cross interactions with other medication is not known, and some of them may lead to liver issues. Alternative therapies include black cohosh, flower pollen extract, phytoestrogen supplements, vitamin E, dong quai, evening primrose oil, and cannabis. Brain fog, depression, and dementia. This is an area that requires well-researched facts. There's so much cultural narrative of a woman's competence linked to her hormones. We are accused of being hormonal when we're premenstrual, when we're pregnant, when we're postpartum, and then when our body gets rid of those toxic hormones, we're now considered unable to function. So it's important to really stick with the facts. The brain is influenced by estrogen. It's made either by the ovaries and even in the brain itself. Estrogen increases blood flow, enhances brain metabolism, and improves connectivity. It also boosts serotonin activity, which is a neurotransmitter involved in mood, memory, and executive functioning. But this does not mean that a woman's brain is unable to function without estrogen. Estrogen is only one piece of the whole puzzle. A woman's brain has unique plasticity. It adapts to what we are doing in our lives and where we are. It can change or rewire in response to hormonal cues. This is what allows a mother to be so super attentive to her newborn baby's needs. Hormonal changes cause her to refocus on the care of the newborn. This doesn't mean she's less capable to do other things, just that her main focus at that time is care of the infant. This drop in estrogen explains the brain fog that settles in around perimenopause. Everyone worries that they're developing dementia, but dementia up to age 65 is very rare. Most women will notice a reversal of memory difficulties once they become postmenopausal, or at least a halt in deterioration. So there's hope. You can try protecting your brain function by making sure your cholesterol, blood pressure, and sugar are controlled. Avoid smoking and excessive drinking. Exercise about 150 minutes per week. Manage weight. Stay socially connected. That's something COVID taught us about the elderly. And maintain cognitive stimulation, like reading, crosswords, etc. More research is needed before we can say whether hormone replacement improves memory and focus for all women. But Dr. Haver suggests increasing the omega-3s in your diet by eating fatty fish, nuts and seeds, and vitamins C and E, for example, in sunflower seeds, almonds, and leafy greens. Genitourinary syndrome. This is a group of symptoms affecting the vagina, vulva, and bladder. There's a wide range of symptoms. It's very common, but often goes untreated out of embarrassment or lack of awareness. Symptoms may include urinary incontinence, chronic UTIs, decreased sexual arousal and pleasure, decreased lubrication, resulting in irritation, discomfort, and dryness of the vulva and vagina. Vaginal estrogen is the gold standard of treatment. It comes in the form of creams or vaginal tablets, whichever you prefer. There are also suppositories that contain something called DHEA, which is broken down by vaginal cells into estrogen and testosterone. This is considered safe even for those with breast cancer using aromatase inhibitors. The one in Israel is called Intrarosa, and I've had a lot of success with it. Most of my ladies, though, with recurrent urinary infections are resistant to vaginal estrogen. They'll use it for a bit, claim it didn't work, and then stop. So I have to emphasize that they need to use it for at least 6 weeks, ideally 3 months, for them to notice any improvement. Okay, so what about hormone replacement? As I said before, hormone replacement is approved for the treatment of hot flushes, night sweats, prevention of osteoporosis, treatment of genitourinary syndrome of menopause, and treatment of primary ovarian insufficiency. This means that HRT is effective for these conditions, and for most women, the benefits outweigh the risks. You don't have to be postmenopausal to start. Hormone replacement therapy can be used for other symptoms, the ones that I mentioned previously, but this is considered off-label use. It hasn't been approved by the FDA. There are, however, guidelines by reputable organizations that have looked at a lot of the literature available and have made recommendations. So a classic example would be the use of hormone replacement to control irregular bleeding during menopause transition. So the health benefits we can see from hormone replacement that can be considered for some women is a reduction in colon cancer, an improvement in depression, reduction of cataracts of the eyes, a favorable effect on metabolic syndrome, combined with exercise may help muscle loss. The skin may slow the appearance of wrinkles, sleep, reduced weight due to hot flushes, and type 2 diabetes, 19 to 40% reduction. At the moment, it's not recommended for prevention of dementia or Alzheimer's for women at average risk. So if you are perimenopausal, you need to have a discussion with your gynecologist. At my last gynae appointment, I was asked, do you get hot flushes? I replied, no, and that was our discussion. So it is something you need to broach, you need to bring up, you need to discuss whatever you may be feeling, your symptoms, your feelings, and push the agenda to get your gynecologist's opinion as to what is the best treatment for you. Together, you can discuss the risks and benefits and come to a solution. Breast cancer, endometrial cancer, previous clots, stroke, or heart attack are considered risk factors and may be contraindications, but are not total contraindications and will depend on your specific medical history. Once a decision is made, then you need to look at the options. Estrogen comes in various forms as a gel, a patch, a vaginal ring, or a tablet. The transdermal route, that's through the skin, like the gel or patch, is considered the safest as it doesn't bypass through the liver and has a decreased risk of blood clots. But some women get an allergy to the sticker, to the gel, they can't tolerate it, and they may choose to take the tablet form. Estrogen taken on its own can lead to endometrial cancer, but progesterones protect the lining of the uterus from the effects of the estrogen. So progesterone needs to be taken with estrogen if you still have a uterus. If you've had a hysterectomy, you don't need the progesterone. Progesterone also helps with sleep issues and can help to alleviate hot flushes, headaches, night sweats, mood swings, and vaginal dryness. It can be taken only as a sequential treatment for just 10 or 14 days of the cycle, but it's just easier to take it with the estrogen as one tablet. If you have a Mirena, which is an intrauterine device that has its own progesterone, you can use that to oppose the estrogen, but you won't have the systemic benefits of progesterone. So many health providers in America prescribe off-label testosterone. It is not FDA approved, and I prefer not to comment on it as it's not available here for women. Birth control and hormone replacement. The birth control pill and the hormone replacement tablets are made of the same hormones, but they have different dosages. The birth control pill actually has a higher dosage because it needs to suppress ovulation. So many women took birth control pills for many, many years, but then when it comes to hormone replacement, they feel no, they don't want to go on to those kind of hormones. So it is something to consider. The question is, up to what age does a woman need to be using contraception? At the age of 40, a sexually active woman has a 5% chance of getting pregnant with each cycle. By the age of 45, 55% of women are no longer able to get pregnant. By age 47, 79% are no longer able, and by age 50, 92%. Pregnancies in this age group are uncommon, but they can happen. And I think many doctors have dealt with a patient who mistakenly thought her lack of period for 3 months was menopause. There is no blood test or ultrasound that can confirm when she should stop contraceptive use. There are blood tests to measure your FSH, your LH, but it's such an erratic time of hormones that you can have high levels of FSH or LH for months and then actually ovulate and get a period. So it's very inconsistent. Women under 50 should continue contraception until 2 years after the final menstrual period. Women over 50 should continue until 1 year after the final menstrual period. Older than 55 can stop. I have a very lovely 50-year-old mentally retarded patient, and her sweet, sweet elderly father is her primary caregiver. He brought her to me as he was concerned that she had put on weight and was having hot flashes. He knew her last period had been 2 years ago, but he just didn't understand what was going on and what could be done to help her. For me, it was so refreshing to discuss menopause with a male, and I couldn't help thinking how much more supportive it would be for most females to have this consultation with their partners. Menopause can be a lonely, unique experience for most women. Other than a joke about a hot flash or memory loss, it seems we all just get on with it in our own way and stumble through. And I really think something at an event like this tonight is so important to share with other women this interesting, exciting transition in our lives.
Okay, yes, we're gonna have questions. Don't worry. I know. I also have questions. Just gonna quickly set up this screen. Okay, there's gonna be a few minutes for questions after I speak. Watch out. Thank you. Okay, we did it. Woo. Okay. I just want to take a few minutes while the screen is rolling down to say that I've started to talk to you about Matan. Tonight, I'm really wearing two hats, wearing two scarves, embracing two organizations that are really very close to my heart. I spent a lot of time in this building. I've known Osha since I was 18 years old, and we've been through a lot of stages of the life cycle together. And Osha did an amazing thing besides building this beautiful building and creating such incredible opportunities for women to learn Torah in Ra'anana. Osha, together with some wonderful other people, started a program. How long is it now? 8 years ago? Mashu Kazeh. Starting the ninth. What's called Morot LaHalacha, and it started out as a 2-year program where women would be trained at the highest level in Hilchot Nida, the laws of family purity, not only the technical law, but also everything around it. We had tons of enrichment sessions with psychologists and doctors, and we discussed all sorts of things around this topic. We also did not only remain within the realm of Hilchot Nida, we also complemented that with the cycle of the life cycle. And so we learned from the halachot of Brit Milah through different stages of a Jewish person's life, and taking it through Avelut. And this was supposed to be the program, a 2-year program, which in and of itself was an incredible thing. At the end, we were tested at the highest level. And Hilchot Nida, we were tested not only with a written test like the men do, but also I was examined by 3 Rabbanim Poskim, who it was really one of the scariest days of my life. Examined. We'd take an oral exam. Sorry, you're right. I'm a little tired. An oral exam. Great. You're right. I'm sorry. We had an oral exam with 3 Rabbanim Poskim, and we could have stopped there. But Osha said, no, we're not done. And so I, together with a few other women, including Dr. Sharon Galper-Grossman, and who many of you might know from Ra'anana, and Rebecca Linzer, who works at Matan, and a number of other women took another 4 years, devoted ourselves to another 4 years of learning halacha and taking halachic exams in the topics of Shabbat, Hilchot Shabbat, and Hilchot Kashrut. And so altogether, I spent 6 years here studying halacha and enriching myself. In addition to that, I teach classes here, not so much in the field of halacha. In fact, this year, I invite you to join me.
Karen, if I can just emphasize, the important thing is that we believe women can become halachic authorities. And if women can be scientists and doctors and lawyers, there's no reason that women can't be at that authority to answer halachic questions, and especially when we believe that women feel more comfortable to ask women. So what we have done with this program, we made halacha accessible to women and to men as well. We believe that women should be part of the halachic discourse. We have what to say. We have a voice and we have a seat at the table.
Yes.
And really, Rabbanit Karen Jackson went all the way. And we did equivalent to what the rabbis do, and even I would say.
In Hilchot Nida, they say we did more. And I can tell you that it's actually been amazing. I get questions every week, at least one question a week, some weeks more, significantly more. It started out in the beginning, people didn't know what to do with me and how to approach me. And so it started out in the women's section of shul on Friday nights. Every now and then a woman would come over and ask me a question in a shy way. And then slowly but surely it's built up. And so it's been really a zchut to be able to do that. And in addition to that, I was just going to invite you to my Wednesday class here. This year we'll be studying the book of Exodus and the book of Esther with a lens toward what we're going through, the Jewish people, the Jewish nation at this moment in Jewish history. Some of you are already my students for many years and are very dear to me. And my other hat or mitzpachat is that I have been working with Naomi for a long time, and I am the host of a podcast called Women and Wellbeing, where we give a little bit of Torah and then we interview an expert on a variety of topics. And so I invite you to listen to that podcast and subscribe. It's at Eden Center Podcasts, Women and Wellbeing. Okay, so now I have just a few minutes, and I just want to, really the most important thing I want you to walk out of this room with is the following message. Ask questions. I'm going to talk to you about some of the halachic and Torah perspectives on this time of transition in our lives. But the most important thing is to walk out knowing that you shouldn't be shy and you should ask a question. Most often, I think women tend to be strict with themselves, and when they ask a question to a rabbanit or a rav, it's also okay, they are pleasantly surprised that they don't have to be so strict with themselves. And often when we're being strict with ourselves in terms of keeping Hilchot Nida, family purity law, we're actually, there's a price to pay because it has an effect on our intimacy and our relationship with our spouse. So I really encourage you all to ask questions. Okay, so I'm going to talk about the halacha in a minute, but just to frame things, I just want to quote to you. I forgot to put the source. It's from Pirkei Avot. There's a beautiful idea when I try to think about what does the period of transition in our life, menopause, what is an image that it reminds me of in Judaism? I thought about the idea of what's called Bein Hashmashot, okay, which is the time between when it starts to get dark and sundown, complete sundown. And this time period, interestingly enough, depending on where you are in the world, can be longer, can be somewhat shorter. It also has halachic ramifications, which we're not going to get into here. But the imagery of the sun setting, okay, on the one hand, may sound a little oivei, as Joe said, but what it really is a transition from daytime to nighttime. And what happens during that transition time is a very magical thing. And the Midrash even talks about, and Pirkei Avot talk about 10 mysterious and interesting things that were created in the creation story on Erev Shabbat. Before Shabbat was coming in, during Bein Hashmashot. Bein Hashmashot on Erev Shabbat is a very magical time. The Hasidim of Tzfat would go out and start to welcome the Shabbat. And this transition, this idea of a period of time which is not exactly day and not exactly night, is also a time of magical opportunity. And so magical things were created during twilight. For instance, Miriam's well, the mouth of Miriam's well, we're told, was her magical well in the desert was created at this time, several other things. And so this is something that I like to think of as a framing for menopause. We are, on the one hand, starting to lose our ability to procreate, to have biological children. Certain things are changing in our body. Maybe our hair is going gray. Maybe we're having hot flashes, all these other things, as Joe spoke about at length and very interestingly. Thank you, Joe. And at the same time, suddenly we also, our kids are growing up, if we have children, and we can let go in a way of some of the insecurities and expectations that we always had for ourselves when we were younger. And for many women, it's also a time to flourish in our careers, to figure out new horizons that we're interested in, new hobbies. And so I really like this imagery of Bein Hashmashot for this time. Now, what happens when we get to the halachic story? I get many questions from women who suddenly, their whole lives had a regular period, or for maybe reasons of birth control, haven't had a period in a very long time, and suddenly they're around 50, 52, and maybe they've changed their birth control situation, or their period is starting to change significantly, their cycle is starting to change. And so all of a sudden they'll have staining at random times throughout the month. Their period will come much closer together, much further apart. And as Joe said, it's complete unpredictability. And so I even had one woman, which I'll just share with you, who called me up and said, I need your help. I have not had to do the hefsek tara and counting of the 7 days. I haven't had to do this in over 20 years because I had children and I was pregnant or nursing. And then I went on a hormonal IUD and I basically didn't get a period. And so I wound up not going to the mikvah and not having to keep this for so many years. She said, I don't remember anything. I need you to teach me everything. She's like, I feel like a kawa getting married again. And she was 53 years old. So, so I think that there's this, it can be a time where things are really stressful on top of all the stress in our lives. We don't know how to manage this and how to manage getting to the mikvah. And so I want to share with you some quick tips for how to navigate this time. And this is, I think, the most important category you need to know about in Chochmah Nida at this time, which is the category of stains. Perhaps some of you may remember this from Kala classes. I think these things are talked about much more openly now than ever before. And halacha has also, there's been all sorts of new developments and changes in how this is applied today. And so what happens is when you have a regular monthly cycle, a monthly period, that is what would classically put you into Nida, and then you would go through a process of what we call purifying yourself and going to the mikvah. Sometimes, if you're on birth control, or especially at this time of life, you have staining. And then the question is, every time you have staining, what does that mean? Do you have to then do a bedika, a check, and count days and go to the mikvah? That would mean, for some women, this have come to me and said, I'm basically at the mikvah every 2 weeks, and I'm never not, right? I'm never muteret. I'm never in a situation where I can be intimate, be sexual with my husband. So it's very important to know that in halacha, there is a very distinct difference between what's called the flow, the period, and stains. And this comes straight out of the Gemara. We don't have so much time, so I'm not going to get into this, but on a Torah law level, what puts a woman into nida midoraita, biblical nida, is if she has a flow or if she has this thing called a hargasha, which we don't have time to talk about, but it is a unique feeling which most women don't have today of literally her period starting, like literally. We're not going to get into that now. Because of that, the rabbis had to figure out what happens when a woman has a stain, which doesn't seem to be period and doesn't seem to be associated with this feeling. And this is what the rabbis call a ketem, stain. And there's a famous Gemara, which actually is a lovely story. In the Mishnah, actually, where I just want to read the second source, where we hear about Rabbi Akiva. And listen how Rabbi Akiva relates to this woman. Maaseh b'isha achat, shebat lifnei Rabbi Akiva, amra lo, ra'iti ketem. Amar la, shema makah hayta. So this woman comes to Rabbi Akiva. Unfortunately, we didn't have Morot L'Halacha at this time. So she came to Rabbi Akiva and said, I found a stain, I have a stain. And he says, well, perhaps you had some kind of wound. Maybe it's not from a flow, it's you have a wound inside. And she says to him, yes, actually I did, but then it healed. Okay. Amar la shema yachala lehigalea v'lo tzidam. He said, perhaps it reopened. And she says to him, yes, v'tahara. And then he said, okay, you're okay. You can go. It's just a ketem. You are not in nida. Then his students said to him, Rabbi Akiva's students are watching him. Now it's almost like he's playing games with her, right? She's saying, I had a stain, I have a blood stain. And he's saying, well, maybe you have a wound. Maybe, and she said, yeah, I did, but it healed. Well, maybe it reopened, meaning he's searching for a way to help her. And Rabbi Akiva's students say to him, they're looking at each other and they say, what's going on here, Rabbi Akiva? Why are you being such a makil? Why are you being so makil and so lenient? And he says to them, Ma hadavar kashe be'inechem. Why is this so difficult in your eyes? Shelo amru chachamim hadavar lachmir ela lahakel. The sages set up the law regarding stains only to be lenient, not to be strict. Okay, meaning that when we have what's just a stain and not a flow, the rabbis are going to aim to be lenient as much as possible. Now, there's certain guidelines for how to do this. So if you're finding yourself in a situation where you're having stains for 2-3 months on and off, what are the ways to prevent going into halachic nida and having to count the days and go to the mikvah? So there's a couple of guidelines in the first box. There's a couple of issues. First of all, the blood stain, okay, the ketem, if it is on colored underwear, if you find it on colored underwear, okay, this is number 2, the material that it's on, or a panty liner, or toilet paper, it is going to be okay. It is not going to be a problem according to Jewish law. Whereas if you find it on, let's say, white underwear, okay, there it has to be a certain size, okay? So that's the number 1, the size. And so these are the kind of things that you want to call a Morah L'Halacha. We have a wonderful hotline here at Matan, and there are many women throughout Ra'anana who have trained here in this, several women, not many, and you can talk to them and understand, what is this? Is this a stain or is this a flow? So when you're not in nida, it's always advisable to wear colored underwear, to wear a panty liner. Now, in terms of toilet paper, it's a machloket in Jewish law, but for the most part, most rabbis hold that it does not receive impurity, tuma. In which case, when you see a stain on your toilet paper, you might think, I'm in nida, but it's actually not the case. However, for reasons I don't have time to get into, it's important to always pause for a few seconds between urinating and wiping. And so the key things here are to wait a few seconds after urinating and wiping with toilet paper, to wear colored underwear, and the other thing is that when blood stain is found on something which has been internal, like a tampon or a badika cloth, it's much more difficult to not go into nida. And so I always say to people who call me, try not to put anything internal. If you get the staining, don't put in a tampon, just use a panty liner. Okay, the other major thing is that sometimes we have blood stains because of a medical procedure that was done or some kind of wound. Again, these are all things you can call and ask a Morah L'Halacha about, because this is what Rabbi Akiva taught us, that if there's something that we can be toled the stain on, tzliya, then we can categorize it as a stain and not a flow. And of course, the final thing is the color of the stain. So these are things that would help us distinguish between what's considered in Jewish law a period, a flow, and what's considered a stain. And it's super important to keep these in mind and to ask questions, because very often women will come to me and say, I don't know if I'm in nida or not. And I ask a few questions and it becomes clear that it's just a stain and she's not in nida. And if perhaps at this time she is in nida, I give her all these guidelines and tips and walk her through this to help her understand what she needs to do next time to keep herself out of nida. The reason why this is really important is because at this stage of life, you can have staining, get yourself into nida by accident, and then get your flow, and then find that you're constantly in a state of nida. And so this is what we're trying to achieve to get this. Yes. Yeah, so it's a technical amount in the Gemara, which is it's a debate what exactly it is, around the size of a shekel, maybe a little bit bigger, but it also can be, depends on if it's, sometimes we add, sometimes there can be a stain of different colors, and we've also been trained, don't be grossed out, but we trained in how to look at the Gedika class, just like the rabbis do. And so yeah, so just to avoid becoming nida from stains, just to continue, wear colored underwear and or a panty liner. Don't look at the toilet paper, or if you want to look, just make sure you wait between urinating and wiping a couple of seconds. I feel like with everyone having cell phones, that's never a problem anymore. Don't have put anything internal if you don't have to, okay? Nothing internal, no tampons, no Bedika class. Never do a Bedika class unless you're sure you have to do a Bedika. The other thing it relates to after having sex, to always have colored or dark sheets, not white. Again, any blood stain found on white is going to be more problematic than on a color. So use colored sheets. And after sexual relations, you can want to be careful. You can wipe yourself with a dark towel, wait a few minutes before going to the bathroom, because there's a whole Jewish legal story about seeing blood stains after sex, which I don't have time to get into now. You'll just have to take my word for it, or I'm happy to tell you more another time. But this was just to give you a sense that on the one hand, it feels like we're being set up for failure, right? With this halachic system, when you hear about it at first and you find that in the perimenopause, suddenly your period's totally unpredictable and out of whack, and it feels like you're going to be in nida for 5 years straight. But if you speak to a moral halacha and understand that it's actually much more nuanced than that, it can actually be the case that you can keep it under control and keep yourself in the status of not in nida for much of the time. Okay. The final thing I'll share with you is the idea that the question is, well, when do you know that you're actually no longer, right? When you reach menopause in halacha, when can you stop keeping all of these halachot? And I also recommend one of the breakout sessions, Naomi is going to be speaking about saying goodbye to the mikvah. Some women are very happy to say goodbye to the mikvah, others are more sentimental about it. And so I really recommend all three of the amazing sessions we have soon. So the Gemara teaches us two things. First of all, as Naomi tried not to mention, but mentioned, the Gemara does talk about a woman at the point, I won't say the word, but where she's called Ima, which sounds funny because we're called Ima since we're very young, but in the Gemara it means like Safta. And so there the idea is what they talk about, they have an understanding of a woman reaching the stage of life. And basically in Halacha, we know that once a woman goes 90 days without menstruating, which is totally possible in this phase, she's what's called Mesuleket Damim, okay, no longer bleeding. And she doesn't have to do something called Onot Prisha, which is, if you know what that is, then you can go with this, and if not, happy to tell you more another time. However, it's possible that what will happen is you won't get your period for 90 days, or even half a year, and then you'll start having a flow, or you'll stain. And so that is when, again, you come to Matan, you come give me or someone else a call, and we'll help you through that. But this is what the Gemara talks about in terms of reaching that other phase. And so again, what I want to leave you with is how I started, which is the importance of asking questions. We're here to help you, and I feel it's a zchut that I've been blessed with the opportunity to study this and to be able to help people in this way. And so with that, I want to thank you all very much for coming tonight. We have time for a few questions, and after that, we're going to go into our 3 breakout sessions with Naomi will explain after. Okay, questions, and maybe she'll come up. I assume the questions will be more. Questions?
Talking about starting the hormone replacement therapy after, before it's finished, before you've gone through the menopause.
Yes.
It's say like 5 or 6 years.
Yeah, so I was talking about when you look at the cardiovascular benefits, if you start within 10 years of your menopause, then it does have a benefit. But if you're starting after 10 years, that more than 10 years, then it's actually not going to give you any cardiovascular benefit. If you're still having symptoms, then it's definitely worth looking into your risk factors and anything else that may be. Yes. Yeah, you're not going to reverse, but at least with any osteoporosis medication, you're going to definitely halt the deterioration. Yes, if you have any symptoms. It is indicated for flashes. If you're having flashes before and you're still getting your periods erratically, or even if it's regular, but you're having hot flashes that aren't really affecting your quality of life, it's definitely worth looking into. It may be worthwhile because you're still getting a regular period. It may be better looking at birth control pills because you're getting estrogen, but you're still getting contraceptive benefit.
And then you said the progesterone is also that.
Testosterone.
Okay, so the progesterone is that.
Progesterone is that.
It's like a whack tablet.
Yes. Yeah.
Fibroids an issue
That's very dependent on how big, how much. Yes, they can still bleed after menopause. Yes, they can. I don't think they would grow bigger, but if they're there, they're there. They're not going to. They may shrink a little bit, but if they're there. No, you're not going to get a regular menstrual cycle. If a woman after menopause has a vaginal bleed, she should go see her doctor and get that checked out, because that's considered a warning sign of things that need to be checked out. That makes sense. There are some and some, so it just depends. I must be honest, I don't often prescribe hormone replacement therapy here in Israel. I would refer to a gynecologist. So I'm not really familiar with exactly what is available here or not. I prefer bioidentical. Bioidentical is definitely your first choice. You want something that's going to be as similar to your own body's hormone as possible. And there definitely are bioidentical participants.
Thank you. I'm going to stop questions here and everybody can come up to you. Thank you. Very much appreciate. I want to tell you what's happening next so we can hopefully stick by our 9:30 end session. Very impressive. So first of all, I want to say thank you to Bracha for bringing a lot of the refreshments, and there are recipe cards downstairs that follow the healthy nutritional things that you need now. But if you want to hear more about the nutritional needs during this time, so Elia is going to be talking about changing nutritional needs in midlife in this room. Millie, thank you, is going to be talking about will your pelvic floor love you at 75? in Tina, which is the farthest room, and I'll be doing a creative workshop, but talking about how to say goodbye to the mikvah in the middle room. But before we all disperse from here, because we're gonna go straight into those rooms, I wanna say that tonight our goal was opening a conversation, giving you some resources, and we will send an email with lots of resources. So if we don't have your email, please give it to us so you can get all the contact information. And basically increasing our knowledge about menopause, so we all know we're not alone. There's all of us, look around you, are going, will go, have gone through menopause, and we're all women, we all feel it differently. But I want to charge you with 3 things, okay? Because I'm not going to do it at the end. Read the booklet. See what it has in it. See what speaks to you. Add to that conversation. And if you want to take it for a friend, a sister, a neighbor, I don't know what, there are extra copies right outside the door. The second thing I want to charge you is to get involved in Matan and Eden, make a donation, host a program, whatever you want to do. But this only happened because of the committee, and I thank you all again, who were willing to stand up and say, I'll do that, I'll be here, I think it's an important conversation, and I'll do that. So thank you again, and I have something for each of you afterward. I'm just conscious of the time. And the third thing and final thing is that there was a lot of information, and there will be even more interesting information in the breakout rooms. I ask you to share at least 2 things with 2 different people. You could do it by posting on Instagram or on Facebook. You can do it by speaking to a friend on the phone, by having people at your Shabbat table, by whatever. You can talk about it. Oh my gosh. Okay, whatever way. But to share it forward, because the point of the evening is not for it to remain here. Your children all know when you're going through menopause. So thank you for coming and participating. Please share your voice. And please let us know, as I said before, if you want to add to the conversation. So Millie is all the way at the end of the hall. Tina, sorry, that's the Tina room. Elia is here.
Okay. Hi, everyone. Right, yes, I get it. Lovely to see so many familiar faces. For those that don't know me, I'm Elia Greenfield. I'm a registered clinical dietitian and have a private practice here in Rai'nana. I want to take this opportunity to thank the Ellen Setze and Matan for hosting this evening and also for inviting me to come speak. And a big shout out to you guys for actually coming and wanting to take action and find out more about your health. We all got very busy schedules, so kol hakavod. Okay, so I've been given supposedly 20 minutes, but it's already 9:15 and we all want to go home and I personally want to put on my pajamas, so I'm going to try and fly through. It's a very, very, very vast topic, and it was one of the biggest challenges trying to condense it into the time we have. And I was also trying to find the balance of not throwing out information overload, but still enabling all of you to go home with some take-home messages. So we'll see how it goes. In 2018, there was a study published in Leeds in the United Kingdom that covered 900 women aged 45 to 60 over a 10-year period, women that went into menopause naturally. So it wasn't surgical menopause, but natural menopause. And one of the interesting outcomes of the study was that women who ate more fatty fish and legumes delayed the onset of menopause by 3 years. And those that ate more processed foods brought on menopause 1.5 to 3 years earlier. Now, this is more for perimenopausal crowds. Those of us who have gone through menopause already, don't be disheartened. There's still a lot we can do, but it just shows what an important role nutrition plays in what's going on in our bodies at this stage of life. So I wanted very briefly, Joanne ran through the main details of menopause, but I just want to very briefly run through the 6 hormones and how that kind of shift at this stage of life, because it is going to help us understand how nutrition can meet our needs. I then want to quickly define what our health goals are, because we want to all be speaking the same language. And then obviously the role of food, a bit of sleep and stress, and then tips to go home with. Okay, so the power of sex hormones, there's basically 3 main sex hormones in female bodies. Testosterone, surprising fact, we've actually got more testosterone than we do progesterone and estrogen. Testosterone starts declining in late 20s, but what ends up happening is from around the age of 35, our progesterone levels start to decline, and it can be quite subtle in the beginning with no major side effects or symptoms. And then what women tend to notice is that the periods will generally either become more frequent or a little bit less frequent. A lot of women experience heavier bleeding, but it's not necessarily the case. Women describe mood swings. Husbands complain of severe PMS symptoms and also sleep disturbances. During this perimenopausal time, when progesterone is getting lower, our estrogen also tries to compensate. So relative to the progesterone, we've got more estrogen. So we're in an estrogen dominant state, and our estrogen's trying to fix things a bit. And then the estrogen also starts tapering down, and it becomes quite erratic. So at stages where we'll have estrogen surges, and then estrogen will taper down. So a bit of what Dr. Dan was saying, it's very hard to take blood profiles because you could be going for a blood test, and on that specific day, your estrogen is surging, but it's not necessarily a reflection of what's going on over a 6-month period. So what does it actually mean for us? I like looking at estrogen as a CEO of the body. I actually think that estrogen and progesterone should not be called sex hormones personally, because they play a massive role in our body. And really, estrogen, we've got hundreds of estrogen receptors around our body. And without estrogen, things start to go wonky. And that's why menopause is such a complicated time for women, because women experience it in so many different ways. And I was actually listening to a podcast a few weeks ago with a medical doctor, a woman in her 50s. And she actually said that, I'm really embarrassed to tell you the story, but when I was a resident in the 80s training, the senior residents, she was a junior resident at the time, and the senior residents would come in and go, oh gosh, you've got a WW. And everyone would just roll their eyes and pat her on the back and say good luck. And she says, I'm embarrassed to tell you, but a WW stands for whiny woman. So women would come in with all these symptoms and would just be brushed aside. And I was speaking to Karen earlier on and just saying how important this is for us to open this conversation. Karen also mentioned, to discuss at the Shabbos table, and there was all a bit of a giggle. But quite honestly, I think we need to have this conversation. We have these conversations with our husbands, our partners, our sons, our daughters. I see my mother, I hope she doesn't mind me saying this, a woman in her 70s who struggled for many, many years with symptoms because she was advised that HRTs weren't good for her. And so I really do feel very fortunate that we're of a generation where there's so much more research and that we can really advocate for ourselves. Okay, so with estrogen being the CEO of the body, it plays massive roles in our brain function. So when we experience brain fog, tip of the tongue issues, I've been experiencing that, and my biggest fear is going to happen tonight. It may happen tonight, but it's that need to search for a word and you just can't find it. Metabolism, bone and heart health, muscle mass, and cellular energy, just feeling more tired, just generally feeling like a little bit more sluggish. And I don't know if any of you have noticed, but also changes in our bodies. Without doing anything different to our lifestyle, all of a sudden we're starting to notice more fat around our belly, around our back. Unfortunately, over each decade, once we hit perimenopause, we lose about 5 pounds of muscle mass and gain at least 5 pounds of fat without doing anything different. So again, I'm not here to depress you, but unless we do something active at this stage of life, we're heading in a not such a fun direction. Okay, so this, for me, if this is the only thing you guys go home with tonight, then I feel my work here is done. We live in a very thin-centric world, okay, especially the Western world, where we look at thin people and automatically assume they're healthy and overweight people are unhealthy. There have been a ton of studies even on doctors' bias, where an overweight person or obese person will walk into a doctor's clinic and there's automatically a subconscious bias against that person. I was actually speaking to an endocrinologist this morning, and she said that she, and this is a female, had a situation where she actually overlooked a patient because she was overweight and there was something underlying going on. The reason I'm mentioning it is because at this stage of life, and please God for the next 3 to 6 decades, until 120 for all of us, the focus needs to be on being strong, not small. Okay, it's not about being skinny and trying to fit into our 20-year-old bodies, but it's about living in vitality with strength and health. We want to have much less chances of having fractures and falls. We want to have energy, we want to run around after our grandchildren, our great-grandchildren. So the focus of tonight, and please God for the next 6 decades for everyone, is to be strong. Okay, so what's going on? Dr. Joanne alluded to this as well. We'll go into slightly more detail, but basically one of the first things that happens when estrogen starts tapering off is we do become more insulin resistant, which means that 20-year-old you, when you'd eat a certain amount of a carbohydrate, your body would need to pump out a certain amount of insulin. Now, your body, for that same amount of carbohydrate, needs to pump out double or triple that amount of insulin in order for your body to absorb it. What's the problem? There's 2 main issues. The one is that your pancreas that actually produces the insulin gets tired. The pancreas likes working 8 to 5. Okay, it doesn't like working overtime. So the minute we ask the pancreas to overwork, in a decade, 2 decades time, your pancreas is going to stop producing insulin, and then we're staring and looking at type 2 diabetes. The other issue is that insulin plays a massive role also in storing fat in our body. So the more insulin we have floating around in the background, the more our body's primed to store fat. And guess where the body wants to store the fat? Around the belly and the back. So what can we do from a nutritional perspective? So we should switch to more complex carbohydrates just in general. So what am I talking about? Carbohydrates that are filled with fiber, that take longer for your body to absorb and are easier on your system. So whole grain, sourdough breads, quinoa, wild rice, buckwheat. The other thing is to be clever about our carbohydrate intake. It's about the timing as well. Exercise makes us more insulin sensitive. So after a nice workout, great time to have a nice carbohydrate-focused meal. We can mix up carbohydrates with protein and vegetables. Protein and vegetables create a mesh in our stomach, which means then that it takes our body longer to absorb the carbohydrates, easier on our system. And the last thing is something that I've really been pushing my clients to do recently, and I'd love for each of us to do this if possible. But there's something called a CGM, a continuous glucose monitor, which is a patch you put at the back of your arm. It's linked to an app on your phone, and you basically get a 2-week reading of your glucose levels, and you can track exactly how your own body is responding to carbohydrate intake. How cool is that? That you can then work out exactly how you personally respond, and not only how you personally respond to a specific carbohydrate and amount, but also to the time and day. You have a sweet potato at 12 o'clock and you have a sweet potato at 6 p.m. How's your body responding? And then based on that, we can have a more targeted approach.
Can you get them in Israel?
You can. It's hard to get them through the cookbooks. I've been talking to a few doctors about it, but there is a company called Geffen Medical. I'm happy to send out the link. You can order it through them. Don't be frightened though, because the pricing on the website is not the actual pricing. So I recommend you call them and I can give you a package. And also to get the Israeli one, don't be tempted to order on Amazon because you need to link into the Israeli app for it to work. Okay, bone density and muscle mass. Estrogen plays a massive role in strengthening our bones and our muscles. Okay, now what's the issue? Besides the fact that we have these fancy words, osteopenia and osteoporosis, the biggest issue is that elderly people fall and fracture a bone. And unfortunately, we know what the outcome is there. And when it comes to muscle mass, when our muscles get weaker, it becomes a double whammy. Because muscles not only keep us stable and actually prevent us from falling, it increases our basal metabolic rate. So the more muscle you have, the more energy you're burning. And that also, it helps increase your bone density because it creates more weight on your bones. So just by standing and moving around, you're improving your bone density. So how can we try and counter this? Calcium-based foods. Dairy products are my favorite. And yes, I know there's a lot of talk, is dairy good, bad? It's a conversation for a different time, but I'm personally a big fan. If you've got lactose intolerance or other issues, then you can go for dairy alternatives, but always look for an added calcium dairy alternative. If you enjoy eating tofu, look for the added calcium tofu. You can get it through some vegetables. Our body doesn't absorb calcium as well. You can still absorb some calcium through veggies, but it's not the best source, but still recommended to have. Vitamin D supplementation. So this I recommend that anyone who hasn't had the vitamin D tested in the last year or two, go to your family doctor, ask to test your levels. If you're deficient, then I personally would recommend a supplement. This is a standard recommendation, but it depends on how deficient you are. And then for muscle building and muscle mass, we want to have adequate amounts of lean protein. Dr. Joanne said about 1.2 grams per kilogram. So it's between 1.2 and 1.5 grams per kilogram of your current weight. Again, it's something that can help calculate personally, individually for you if you need that help. Okay, estrogen plays a massive anti-inflammatory role. A lot of women at this stage of life complain that their symptoms get worse when it comes to allergies. Some women develop autoimmune diseases. Those that have already had autoimmune diseases, the symptoms get worse. A lot of women complain of frozen shoulder, gut issues, arthritis, and arthritis gets worse. So we want to avoid as much as possible inflammatory foods, which are deep fried foods, fatty foods, excessive red meat intake. Red meat intake is okay, but just not having it every single night. And then we want to increase the anti-inflammatory foods. So fruits or veggies are healthy fats coming from plant sources, such as olives, avocado, seeds, nuts, and then our fatty fish sources. Okay, the microbiome. Now, if I had another 3 hours, it probably still wouldn't be enough, so we're quickly going to skirt through this. But we've got over 100 trillion microbial cells in our large intestine. Research has exploded over the last 10 years. And basically, the amount of cells we have weighs as much as our brain does. And the researchers are actually referring to the microbiome as our second brain. Now, there's a bi-directional relationship with our gut microbiome and our sex hormones. So they like each other. The healthy gut bacteria and our sex hormones really like each other, and they'll work together, and they also help produce one another. So we know that high levels of progesterone and estrogen promote greater gut bacteria, healthy gut bacteria. And we've also seen that from the age of 40, the diversity and the abundance of the healthy gut bacteria starts dwindling. So we particularly see that a reduction in two very important strains of Bifidobacterium and Lactobacillus, which is healthy gut bacteria, and unfortunately, an increase in the harmful bacteria, Enterobacter. What does it actually mean, though? A healthy gut microbiota is associated with an increase in absorption of calcium. So we see there's almost like a bit of a chicken and egg scenario going on here. We need more estrogen also for bone health, but also if we don't have the right gut microbiome, our body also struggles to actually absorb that calcium. We also know that a healthy gut microbiome reduces risks of breast cancer, inflammation, obesity. They've done some very cool studies on overweight people where I think it's cool, you guys will probably think it's gross, but where they actually implant, they do fecal implants from lean individuals into overweight individuals without changing anything with their lifestyle, and the overweight individuals lose weight just from the fecal transplant. So it's pretty insane. And then also improve blood glucose and fat metabolism. Okay, so what does it mean when we have disruptions in the gut microbiome? So our symptoms of menopause get worse. We've got a gut-brain axis. Our gut communicates directly with the brain, so we have more severe mood changes. It can affect cognitive or make cognitive decline worse. Weight gain, heart issues, and then the gut symptoms is something I really wanted to touch on. Women who've already had IBS before menopause, this is less relevant in the sense that probably their symptoms will get worse. But this is more for women who've never had any IBS symptoms and start getting them now at this stage of life. It's most likely not IBS, but it's just the change in the gut microbiome. And the biggest issue is that it becomes misdiagnosed. So then women start avoiding high FODMAP foods, which is what's recommended for IBS. But those high FODMAP foods is actually the food for the healthy gut bacteria. So what can we do? We need to make sure we're having adequate amounts of fiber. In America, the average woman has about 15 grams per day. Here it's probably a little bit more, but not much. But we need to aim for about 25 grams a day of fiber. We need to drink plenty of fluids. Physical activity also helps the gut microbiome, and it also builds muscle. The recommendation is a minimum of 150 minutes a week, but divided into a third cardio, 2/3 resistance training. Women's bodies do not like stress, especially at this stage of life. If we overdo the cardio, we increase our cortisol levels, which also causes many more issues along the lines. So what does cardio look like at this stage? The recommendation is that when you're working out, you're able to have a lovely conversation with a friend, but you can't sing a song. That's pretty much the rate that we should be going at. Rob's, you're fine. Okay, then stress reduction. Okay, I want to get you guys to all do something with me. This to me, if this is all you guys can do in your day changes, as crazy as it sounds, it can really improve your metabolism and just your general state. So we are designed to be in a relaxed state. That's what we were designed to be. But in today's day and age, we are most 90 to 95% of the time we're in fight and flight response. Just with the Western world, our stage of life, we're the sandwich generation, we've got elderly parents, we've got kids, it's coming at all angles, work. And so what we need to do is we need to try to counter that. How do we do that? We switch on what we call the vagus nerve, which is a nerve that runs straight from the brain all the way through the body. And the vagus nerve is our calming nerve. So what I want you guys to do with me, I want you to imagine that your stomach is a balloon. And what we're going to do in a minute is we're going to breathe in and fill up this balloon to make this balloon as big as possible. And then we're going to slowly breathe out, and we're going to squeeze the air slowly out of our stomach. How do we know we're doing it properly? I'm going to get you to all put your hand, one hand on your chest and one on your stomach. I'm going to put this down. And when we breathe in, make sure that the hand on your stomach is moving, but the hand on the chest is remaining still. We're going to breathe in, imagine that our stomach is this balloon, and we are slowly going to exhale. Okay, you guys ready? Let's go. Okay, we're going to do it 2 more times. Last time. Who here feels a little bit more relaxed? We're not ready. Okay, so what I recommend you do is practice this. Okay, as you can see, it's an exercise that only takes probably less than a minute. To do it multiple times a day or even once a day, you find you're getting stressed or your energy levels are being depleted. You could be sitting in the car at a traffic light. Practice this breathing exercise. What we're doing there is we're switching on the vagus nerve, which is improving our gut microbiome abundance. We're reducing our cortisol levels, so we're becoming more insulin sensitive. Sleep. I don't have a lot of time to speak on sleep. In fact, I've got no time looking at the time. But it's quite ironic that I'm talking about sleep at a time when our hormones are disrupted already and don't let us sleep. But just interestingly, that caffeine lasts in our body for about 12 hours after we've had coffee or Diet Coke, whatever it is. So if you're having a coffee at about 12 in the afternoon, when you try to go to bed at 11 o'clock at night, you still got a bit of caffeine in your body. And I sometimes get clients who say to me, but hang on, I don't have an issue falling asleep. I can drink coffee at 10 o'clock and I still fall asleep. The missing part of the puzzle though is the sleep quality. We need to make sure we're getting at least 60 minutes of slow wave sleep a night, which you cannot know unless you have these apps and you're actually measuring your sleep. So you could be falling asleep, you could be sleeping, but you're not in the right state of sleep. So my recommendation is, from a caffeine addict myself, is to try your best not to have caffeine later in the day.
How much is decaf?
Good question. So decaf far less. Decaf's probably got about a third of the amount of, well, probably less, about an eighth of the amount of caffeine. So it'll probably take about like 2 to 3 hours to come out. So you probably could get away more with decaf later on in the day, but not 2 to 3 hours before bed. Okay, so quick tips. I'm going to run through this because I'm trying to get everyone out of here. But to aim to eat about 30 types of fruit and vegetables, herbs, spices in the week, to aim to have 2 to 3 serves of dairy products a day, check vitamin D levels, and supplement if need be. There are some food sources, but they're not fantastic. 2 to 3 serves of fatty fish, cook with extra virgin olive oil, go for quality carbs, okay, rich in fiber, low GI, spread protein throughout the day, avoid pro-inflammatory foods as much as possible, minimize alcohol intake, avoid caffeine later in the day, drink plenty of water, work on stress, breathing exercise, we just did, and you may need magnesium or probiotic supplementation, but that would be very personalized and individual. And I'm happy to chat to people about it afterwards. Okay, promise you I'm almost done. I don't want anyone to feel overwhelmed here. There's been a lot of information before. I've thrown out quite a bit of information here. I do not believe in going from 0 to 1,000. It's not sustainable. We want to be healthy and be vital and strong for a long, long time. So if all of you could just commit to even just one thing on the slide, maybe 2, you're really doing wonders for your health. And really baby steps is what gets us to our goals. Okay, so even if you commit to just having a glass of water in the morning when you wake up, or switching your bread to whole grain sourdough bread, having salmon or walking at a specific time in the day just to get into the rhythm of moving, you're already doing wonders. So menopause is inevitable, but suffering is not. It's really important that we advocate for ourselves. Don't, if the doctor's giving you pushback, push back again, even more, ask questions, make sure you're satisfied with the answers before you accept the diagnosis or how to move forward. I thank you for your time. These are my details if anyone wants to contact me. And thanks for coming.
You can feel free to continue the conversation, but you need to get to sleep.
Drama time.
Thank you, Sarah. Thank you very much.